It works? Good. Not too loud. Very well. Yeah, thank you so much for the invitation to be here. First time I'm here inside of Insound. Of course, I knew where it was, but I had never been inside. I'm Bert Rodenburg. I'm an internist and also an infectious disease specialist in the hospital. Because I'm an internist, and you kindly invited me to have a talk, and I could even determine the subject, I decided to do something outside of infectious diseases. Something that is very common in our practices. The thyroid nodule and hyperthyroidism. It's two random subjects, but we encounter it a lot. For me, it was a little bit guessing what my audience would be today. It's going to be very much focused for internists, but I hope I'll lead you through it and show you how we think and how we work, and I'm sure everyone could pick up something about it. Yeah, so the thyroid nodule. This is what you could think when you mention the word thyroid nodule. Cancer, maybe yes, hardly ever, probably in the back of your mind. Does the thyroid work? Well, you need to do a biopsy sometimes, but not always. Sometimes you need to go to the surgeon to take it out. And you can do ultrasounds, how many, how long, and what frequency, and in who. And multinodular goiter, what to do with that. Now, these are all questions which could pass your mind, and I'll try to give you some answers to that. There's footnotes. Most of the data here comes from the ATA, the American Thyroid Association. They have by far the best guidelines on thyroid diseases. So most of our practice comes from there, and most of the data I have is derived from there. So solitary thyroid nodules are very common. Clinically apparent thyroid nodules, 6% of the women and 1.5% of the men, prevalence. That's already high. If you search with ultrasound in an entire population, 1/3 of the population has a small thyroid nodule, and 12% bigger than 1 centimeter. Now that is a lot. This was a huge German study where they got that data from of 100,000 people, and for some reason they decided to do an ultrasound of the neck in all these people. So you got to make some type of distinction who you're going to follow and who you're not going to follow, because it's very common, as you can see. Thyroid nodules, the incidence increases with age. You can see the age strata, and the older the population, the more the nodules happen. Now, basically, when we see a patient with a thyroid nodule, there's two concerns. Could it be cancer? And does the thyroid work well? That's generally also what the patient comes from. The patient also says there is a funny thing in my neck which doesn't look good. As a doctor, that's not what you think about. You should realize that is sometimes the main concern of the patient. But we usually think, could it be cancer? Now, cancer is not so common in these nodules. This is a big study from Italy. They punctured, FNA is the term you're going to see a lot, fine needle aspiration. That's the biopsy technique which is used to biopsy thyroid nodules. They did a biopsy on more than 2,000 cold single nodules. Cold is a term which comes back later, but these are solitary nodules which are a little bit more suspicious for cancer. So the biopsied those ones. Based on the results, they sent almost 400 to surgery. 5% of the initial nodules turn out to be cancer. That's not so much, 1 in 20. From this cancer, 90% is differentiated thyroid cancer, which have a very good prognosis. If you take them out, the 25-year mortality of young people is 2%. So cancer is not very common, and if it is common, you take it out and it's usually gone. Now, which people get cancer? Because that is how you should think when you see the patient. Some risk factor. Small nodules under 1 centimeter rarely have cancer in them. The bigger the nodule, the higher the risk of cancer. Young people presenting with solitary nodules, especially children, have a higher risk of cancer than older people. That's not entirely true, because really old people, again, have a higher incidence of cancer. But generally, under 20, under 30 years old, presenting with a solitary nodule higher incidence of cancer. If it's a male presenting, it's a higher chance than a female. And you should always ask for the medical history, because of course neck irradiation for whatever reason, stem cell transplantation gives them a higher chance of cancer. Someone presenting with hoarseness or pathologic nodules, obviously you have to be suspicious. I'll be talking mostly about solitary nodules, but what happens a lot also, so I'll mention it, is multinodular goiter. That's someone with a very big thyroid, which is with nodules. What to do with that? Traditionally, we used to say that multinodular goiter doesn't have cancer. That's not entirely true. It doesn't when all the individual nodules are very small, because as I told you, small nodules usually don't have cancer. If within the multinodular goiter there is a big dominant nodule, you should just treat it as if it were a single nodule, because they do have cancer. But because mostly multinodular goiters have many small ones, they don't have so much cancer. But you should look at the ultrasound when you get to see one. Now, what do we do if we have a patient presenting for whatever reason in your office with a single nodule? Of course, you talk to him. You make sure you get a TSH, and you look at the ultrasound. That's basically it. If the nodule is under 1 centimeter, already usually the patient comes to you with the ultrasound, because that's how they get to the specialist. Just check the ultrasound for suspicious features. I'll come to that, what suspicious features are. But if there's no suspicious features on the ultrasound in nodules under 1 centimeter, talk to the patient, tell him it's okay, and send him away again. Because it's very rare to have cancer in those small nodules. Now, the 3 things you should do. Number 1, talk to him or her. As I told you, children or young people be more alert. They have a higher incidence of cancer. Of course, medical history, family history of thyroid cancer, of thyroid cancer syndromes. There's syndrome which involve also the thyroid. And if it's rapidly growing, the patient, of course, will tell you that. Physical examination, of course, if it's hard or fixed, it's suspicious. If there's obstructive symptoms, that means they cannot swallow their meat or fixed food, it's suspicious. If there's lymphadenopathy and if there's hoarseness. Measure a TSH, or look at the TSH which the general practitioner already measured. If there is a functional hyperthyroidism, so a low TSH, that involves a low risk of cancer. Hypothyroidism, so a high TSH, has a higher risk of cancer, and the interesting thing is that the higher the TSH, the higher the prevalence of cancer. It's a very interesting study, which some Belgian people did. You can see the TSH, the higher it is, prevalence of the cancer in a solitary nodule raises a lot. Of course, you also have to treat the thyroid dysfunction with pills. That's a different subject, but it's good to be aware of these risk factors. And then you have the ultrasound. Usually the patient comes with the ultrasound and the TSH already to your office. There's one big rule which I want to state here. If the patient doesn't have a palpable nodule, don't ask for an ultrasound. I think that probably every week I have 4 new patients who come with an ultrasound, either from their GP or from abroad mostly, because someone, for some, to me, strange reason, decided to do an ultrasound of the neck. The patient didn't have symptoms, there was no signs of thyroid dysfunction, but it was a general checkup, general lab. They did an ultrasound of the abdomen, and did an ultrasound of the thyroid. This happens a lot in the world. Don't do it, please. Because there's a very low chance of catching a cancer. Of course, that's why people do it. It sounds logical. But you create a whole bunch of work for everyone, and the chances of catching a cancer is low. Now, if you have the ultrasound, because the patient is there and you have the ultrasound, so you got to do something, you look at the size and you look at ultrasound features. Now, Now this is a little complicated, but it's very important, because you gotta ask the radiologist. Because if you just say, ultrasound, thyroid, suspicion of cancer, they will usually say yes or no. And the question is if it's correct what they say. You should ask them for these features. Ultrasonographic features, this is just from UpToDate, you recognize it. Ultrasonographic features that are associated with an increased risk is hypoechoic. That means it looks black, the thing. The rest is gray and the nodule looks black. Has a high risk. If there's calcium inside, microcalcifications. Now the twinkling on B-flow imaging, I don't even know what that is. I Googled it, I couldn't find it, so skip that. But central vascularity makes sense. Tumors have blood inside. You can see that on the ultrasound. Irregular margins make sense. If it's nice and round, it's not a tumor. Tumors are irregular shaped. You can see that easily. I'll come back to that after. I'll show you the pictures. Incomplete halo. I've asked for it to the radiologist, but they're not so good at it, so I skip it. Nodule is taller than white. Taller than white means it's an egg. Taller than white. Those are suspicious of cancer. If it's a laying down egg, it's not so suspicious of cancer. This is funny, but it's the case, and it's very easy to see. And if it is growing, that's also suspicious. So you should just ask the radiologist for some of these things, and they will give you an answer. That's how easy it is. So if I do it, I ask, is it hypoechoic? Are there microcalcifications? Is there vascularity? Is it taller than white? And that's it. And he will tell you 4 answers, and then you have something you can work with. Here you see what I mean. I hope you can see it. Yeah. So those are all hypoechoic. You can see they're all black. That's hypoechoic. The top one has irregular margins, and it's growing outside of the thyroid. You see there on top. The black and white line, that's the side of the thyroid. And the thing is on the side, it's growing out. That's suspicious. I need a pointer.
You do with the mouse, no?
Ah, there it is.
If you do with your finger on the mouse.
Yeah, this is something that radiologists mostly know, but
You can see the button.
yeah.
It was there for a second. It was there.
Hi. Okay. So, how this works? You look from on top. The probe is on top. On top is the skin. Down there is the thyroid. So these are skin folds. This is the thyroid. That round thing is the nodule. You can see this is the side of the thyroid. You can see this nodule is all the way on the side. It's hypoechoic because this is black, look. That's gray. That's why it's called hypoechoic. You gotta get used to these terms a little bit. Because if you first look at ultrasounds, it looks like a whole bunch of gray things. But actually, if you get used to it, you can see it, and for sure, a radiologist can easily see this. It's good to be aware of what they're looking for. Now, microcalcifications, I think you can easily see that. These white spots, that's calcium. Irregular margin, this thing is not round. This thing is all irregular. And this is the one I'm talking about. This is 2 nodules. So this thing is egg-shaped, you can see that. So then you know what we're talking about. It's easy to ask for, easy to see, and easy to report. Because a lot of decision making is done based on these ultrasound features. Now, then there is like a way how to work. I have just printed it out and put it on my desk. I can never remember. If they're bigger than 1 centimeter, you should always do a biopsy if they're next to the nerve of recurrence or the trachea, if they're growing outside of the thyroid, if there's pathological lymph nodes, well that's obvious, and if it's growing a lot. Now it becomes a little more complicated when that's all not the case, because then you have to look at the suspicious features. So solid hypoechoic lesions, which have suspicious features, which are one of those 4, they're basically the risk factors I showed you in the previous slide. So they're irregular, they have calcium, they're egg-shaped, they have ring calcifications, that means they're on the side. If they have any of those, you should biopsy. The problem is sometimes kystic nodes. They're nodes that have water inside. If it's all water, then it's just water, that's no cancer. But many of them are half kist and half solid. It's a little complicated, it's really hard to biopsy, you can imagine. But the general rule is, if it's more than half water, it's probably okay. If it's less than half water, then you should just consider them as nodes. That's why it says partially kystic. Then, the hypoechoic nodes, which look normal, which don't have all these suspicious things, you can biopsy them if they're much bigger, usually above 2 centimeters. Okay.
The radiologist is the one who told you is more than 50% water or less than 50% water, or you decide?
No. You can just ask him.
Okay.
Yeah. Because actually the bigger the cyst is, the lower the chance of cancer is. It's a sliding scale, so usually we take 50%.
Yeah.
But you have to ask the radiologist. Yes. He will not report it automatically. No, he will not. So, do not perform a biopsy in these cases. Let me start on the bottom. If they're all water, it's no cancer. Leave them alone. Because if you biopsy them, you only get water, you start leaking. Don't do it. Then on top. If they're hyperechoic or isoechoic, that means they look the same as the rest or they're whiter, they're not so suspicious. So you can do it only when they're bigger than 2 centimeters. And you have many below 2 centimeters, I can tell you. So if you do this, many you don't have to biopsy. If they're mostly kystic, that's what I just told you, then usually it's okay unless they have one of those suspicious features I just told you. Spongiform can be sometimes a little bit hard to recognize because that term is not used, spongiform. But they have many microkystic components, that's what it says. Looks like a sponge. They also don't have cancer, unless they're very large or growing further. Okay. I told you before, people with a low TSH or hyperthyroidism have a low risk of cancer. That's a low risk, that's not zero, that's low. What to do with those people? Well, all the guidelines say perform a scintigraphy. Now, I don't think there's any Caribbean island which has a scintigraphy available. We don't. All our islands next door don't. The big ones which have it because you need nuclear material. So we don't have that. Because it says if it's hot, that means that nodule takes up all the nuclear material. That means that's not a cancer, don't biopsy. If it's cold, then you should biopsy. That's what it says officially. But if you don't have that, you've got to do something. So what we do, if there's a solitary nodule, and the patient has hyperthyroidism, so it's TSH low, then we just look if it looks suspicious according to those criteria. Now you know when to do a biopsy. Yeah, you forgot, but this is how it goes. And there's going to be many cases where you didn't have to do a biopsy, so you got to follow them up with ultrasound. Now, you can do it every 1 to 2 years. In basically these, in the spongiform ones, in the mostly kystic ones, and in the small hyperechoic nodules. Because remember, these were the ones you don't biopsy. You can follow them up. The small ones, under 1 centimeters, where you didn't have to do anything with, unless they have suspicious features, you should see again after 6 months, because sometimes all of a sudden they grow, and then it is a risk of cancer. But if you see them again after 6 months and it's still 6 millimeters, then that's it, then you're done. So don't follow up cysts and don't follow up unsuspicious nodules under 1 centimeters. And there is many people with that. This week I had a 14-year-old girl which had a nodule of 8 millimeters who had gone I don't know where, and so I talked to her, the mother mostly, and then you can tell them this is going to be nothing. There's no risk of cancer, and with 1 consult, you're done. Now then you get the results of this biopsy. There has been a big conference, and they made the Bethesda classification for the results to have some uniformity. 1 to 6. 2 is the good one. Don't get confused. 2 is benign. That's what you want. 1 means it failed. They only got water. They didn't see anything. Now, 3 and 4 are usually together. Then you don't really know what's going on. And 5 and 6 is easy. That's cancer. Now, I'll show you how we do that. First, there's the easy results. The benign results, that's good. If your ultrasound was suspicious and your pathology is benign, then you would probably repeat the ultrasound in a few years. In practice, that is hard to organize in Aruba. People forget, they don't come back. That would be the advice. That's what I write to the general practitioner. And if it's growing, then the next time, then you should do a biopsy. The other easy ones are the high Bethesda classes, because they're cancer or they're very suspicious of cancer. You just send them straight to the surgeon to do a thyroidectomy. The not so easy results are the Bethesda 3 and 4. The name already says it, it's undetermined. So it could be cancer, but it could also be benign. They don't really know. The risk of malignancy in those nodules is 10 to 40%. Not so low. And there's 2 types, basically. It's called FLUS and IUS. That's what it means. And the pathologist will just tell you that that's what it is. So the IUS, they're on the high side with risk of malignancy, so you have to send them to the surgeon for diagnostic hysterectomy or hemisterectomy. And the FLUS, if there is a hyperthyroidism, there's a low risk of cancer, remember. You follow them up, otherwise you'll send them to the surgeon. And the non-diagnostics, which happens surprisingly a lot, is the most annoying ones. Because you talk to the patient, you decide to do a biopsy, and then the result is negative. It hurted, he came back after 4 weeks with the result, and you have nothing. You gotta repeat it. Many times, it's Bethesda 1 again, it's non-diagnostic. So then, you have to decide what you do. If based on ultrasound it's not so suspicious, you would just follow them up, and if it's growing, you can do something. If you have a high suspicion based on the ultrasound, then we send them to the surgeon to do a diagnostic hemisterectomy. It's a pity, because you wish it could have been determined with a simple biopsy, but sometimes an operation is needed to find out what this is. That was a nodule. That's basically how we treat them. Part 2, hyperthyroidism. Now, this you probably know, but I'll go through it. Because sometimes the symptoms are not so classical. We know increased appetite and weight loss. Young people frequently present with weight gain, also in my practice, because you get very hungry from a hyperthyroidism, so they eat more. So they come with weight gain, happens in young people. Of course, tremor, palpitations, sweating, heat intolerance, menstruational problems, erectile dysfunction, and gynecomastia are symptoms where not everyone immediately thinks of thyroid problems. Older patients can present with any symptom, or with hardly any symptoms. Of course, atrial fibrillation, usually the cardiologist knows.
One question. How do you spell the gynecomastia?
I didn't look it up. There is interference with reproductive hormones, or it could be through prolactin. I have to look it up. All these hormones are very intertwined. I'm not an endocrinologist, but yeah. All the patients can present with only weight loss, or even only weakness, and it turns out to be a very big hyperthyroidism. So there's a joke. When we have people above 70 years, we do the geriatric lab. Geriatric lab is TSH, vitamin B12, and probably to check for anemia. These are things which present very atypical in older patients. And there are some indicator diseases where you should check for thyroid disease: osteoporosis, hypercalcemia, unexplained myopathy, unexplained heart failure, frequent PACs, paroxysmal atrial contractions. Diabetes deterioration can be caused by hyperthyroidism and shortness of red. These are some indicator diseases.
So one of the symptoms are not hyperactivity.
Yeah, no, I didn't put everything. Yes, you're right.
Yes.
Yeah, that list can be much longer.
Because it weakens also, but I know that they are really hyper, like
Yeah.
more active than usual.
Oh, yes, you're right. It's not a complete list. It's a list of the things which are most prevalent. Graves' disease is the most common cause of hyperthyroidism. Probably you know, but Graves' disease is an autoimmune disease where the body makes antibodies which stimulate the TSH receptor. So the thyroid starts releasing always thyroid hormone. The thing is called TRAP in the literature. They have, not always, but they have eye problems, and they have a diffuse non-nodular goiter. You can palpitate it with the physical examination. It's very smooth, it's big. That's Graves' disease, most prevalent cause of hyperthyroidism. Now, then there is the toxic adenoma or the toxic multinodular goiter. That means nothing else than there is a nodule which is producing a lot of thyroid hormone. Or in the multinodular goiter, there is one or more nodules which are producing a lot of hormone. It's a very distinct disease. It has the same results, but it's good to distinguish them. I'll explain you why. There is finally the thyroiditis, also good to distinguish them from the rest because it goes away by itself. So you usually shouldn't give medications because then you'll make them hypothyroid. So you have to recognize it, but it hurts you. So that's how you can recognize it. And amiodarone. You remember cardiology, amiodarone, yeah. Very complicated. Not so common, but you should look at their medication list. Now, what do you do with a hyperthyroidism? First of all, and hyperthyroidism means the TSH is low and the FT4 is high. You've got to start in the beginning. You get many patients referred with a low TSH and a normal FT4. That is not hyperthyroidism, it's subclinical hyperthyroidism. I get patients referred with both low TSH, low FT4. That's usually either physiological for that patient or it's a lab mistake. So this is where you start. That's your diagnosis of hyperthyroidism. Low TSH, high FT4. You don't always need extra examinations. If it's a young patient with overt symptoms, with eye problems, with a smooth goiter, you have your diagnosis. Don't do a lot of lab and ultrasounds. It's great. But it's not always so easy. Especially when there's no eye problems and you cannot feel the goiter, then you don't know what it is. Then the single test you should do is thyroid receptor antibodies. It has a very good sensitivity and specificity for diagnosing Graves' disease. If they're positive, then you have your diagnosis. If they're negative, it's a little harder because there's mild Graves' disease where the antibodies are so low that they don't come above the cutoff value. So they're normal. So then, if you have no eye problems, if you have no palpable goiter, your antibodies are negative, then it could be a mild Graves, or it could be toxic adenoma or toxic goiter, which you cannot feel. Now, the guidelines say do a scintigraphy. Well, you don't have scintigraphy, because there you can see it very easily. So, what do? We don't send them away. Way too expensive. You can work around it easily. You do an ultrasound. Now, if it's solitary nodule with a hyperthyroidism, you assume that that is the cause of the hyperthyroidism. And of course, since it's a nodule, you remember my previous talk, you check if you should biopsy it. If it's a multinodular goiter, that would be older patients usually. You assume that there somewhere one or two nodules are hyperproducing. Now, what happens many times, it's not to give criticism, but that's how patients come. Yes, tell me.
When you say older patients, from what age? From what age?
40, 50 plus. That's just when multinodular goiter is more common. Many times, the patient already comes with antibodies and an echo at the same time. And this situation has happened more than once. The patient has hyperthyroidism, he has no eye problems, the antibodies are just positive, and the ultrasound has nodules. Now what? If I had done this, I would have never asked for the ultrasound, but I already have the ultrasound. I don't have scintigraphy. No one knows what to do with this. So what I do, I assume it's Graves, since the antibodies are very specific. It says in the literature. I treat him for 1 year, because that's what you can do with Graves. I'll come to that. And then I stop, and if it came back, then I guess I was wrong. Or the Graves came back, or it was a nodule. And then we can see what we do. Usually I've had, I think, 3 cases. Then I do send them out to do the scintigraphy, and then they can treat it right away if it is a nodule. So my message, I'll come back to take-home messages. If you have a hyperthyroidism, ask for the antibodies alone and don't ask for the ultrasound if you're a GP. The first test, if you find a hyperthyroidism and clinically you cannot make a diagnosis, is to ask for TSH receptor antibodies and then send them to the internist. Because we frequently have this problem and then we find ourselves in trouble.
Should you palpate the thyroid?
Yeah.
And if you feel a lot of nodulae,
Then you don't have to ask for
you don't
anything.
have to ask the right?
Okay.
I thought it was a test where you can see just how the TSH is reacting on it. TSH testing, and then you give extra T3 of T4, and then you see how they react on that. Is that the test enough?
Yeah, but that doesn't distinguish between the different causes. I think I know what you mean.
Yeah.
That means you just start treating it
Yeah, and then
and you see what happens to the TH levels.
yes. So
I'm not aware that that is a differentiating feature to differentiate between the different causes. Or maybe I don't understand you well. It's not something we commonly do.
yeah. And then ablation is to cut away.
Oh, sorry, ablation means, I'll come to that after. That means you give radioactive iodine. People just drink it. And it goes all to the thyroid because that's the only place where iodine is used. And it basically burns it away.
It burns away.
It's a nice word for it.
So it's to cut, to kill.
What if your TH test, T3, T4 comes back normal, but you still have a goiter? Would it be hyperthyroidism?
So you're saying your TSH is normal, your T3 and T4 is normal, but you have a goiter. Now that's another subject, because then there's 2 questions. First of all, does it bother the patient cosmetically or obstructively? That could be 2 reasons why you want to do something. I send them to the surgeon or send them for yodum ablation. And the other question is it a risk of cancer? What type of goiter is it? Is it a smooth goiter or a multinodular goiter or a single goiter? Why is it big? So you need an ultrasound there. Finally, once you know what it is, you have treatment options. Basically, there's 3. You can give pills to control it. You can do that iodine 131 ablation, that just means it's labeled with radioactivity, and you can send the patient to the surgeon. There's no one way, also in the guidelines, but I'll tell you some pros and cons to see how we make the decision. First, why would you want to know what the cause is? I have heard colleague internists saying it doesn't really matter what it comes. We just give them strumazole and then you send them back to the GP. These are colleagues of me who say that. I disagree very much. That's why I'm here. Because Graves can be medically treated for 1 year to 1.5 years, and a substantial proportion of those patients stay in remission after for a while. I'll show you some data on that. Of course, people with toxic goiters and toxic adenoma, they don't go in remission, hardly ever. So it's good to think about the cause of this disease, and it's not rocket science to find out what the cause is. Because a toxic goiter, you shouldn't stop treatment after 1 year because you're almost sure they'll be back in your office a month later and have a lot of symptoms and don't go to work and feel very bad. Basically, we use metimazole, strumazole, if you're from Holland. That's the pill of choice because it's once a day, there's a little less side effect than the traditional PTU. There's a treatment scheme. I'm planning to hold this talk also for my colleagues after, so this is very practical, that you have some guidelines how you start treatment. ULN means upper limit of normal. So if your T4 is 2 times the upper limit of normal, so it is 40 instead of 20 if your lab has 20, then you start with 20 milligrams. This is to avoid overshoot. So if you give the wrong dose, you see it back for a week, sometimes the FT4 goes from 60 to 1. This happens, then the patient doesn't feel good. It has some side effects. The mild side effects are relatively common. Skin problems. You can switch to PTU, which is given 3 times a day, has some other problems, and you have 50% chance of success. And there is some gastrointestinal problems sometimes. Then you should just lower the dose if you give it twice a day. Serious side effects, I have not seen them. No, the bottom ones I've seen once. But there are serious agranulocytosis. That means no production of red blood cells, white blood cells, and thrombocytes. And it doesn't give much symptoms, that's the problem. And it happens the first few months, and it gives symptoms once the patient gets a fever and he turns out to be neutropenic. And he presents himself in the ER and everyone wonders why he's neutropenic, that's because of the strumazole. So the trick is to check the blood. If it comes back the first few months, you just check blood build, and then you see. And you tell the patient in the first few months, if you get a fever, then go to a doctor to check your blood. In practice, I have not seen it, but it happens. Hepatotoxicity does happen sometimes. It goes together with this also sometimes. I didn't find any prevalence, but it's a little more prevalent than agranulocytosis. And it's a cholestatic problem, so a bowel obstruction happens sometimes, also in the beginning. Oh yeah, this is what I wanted to show you. It's a very nice study. What they did is try to predict on the diagnosis who is going to go in remission from people with Graves after 1 year of treatment and who will not. So then you can tell them on day 1, I will treat you 1 year and then you have 80% chance on remission. We do that, at least some of my colleagues, we do that. Because you can calculate it. Successful remission happens generally in older people, older in this case means above 40 years old. Young people, it will recur much more frequently. When they have not such a high FT4 at presentation, that makes sense. If it's not so active, then they stay in remission. If the antibodies are not so high, also makes sense. And if the goiter is not so big, these bottom 3 is logical. If it's very active in the beginning, then after 1 year of treatment, it will probably come back. You can make points, you can give points, you can classify these patients. They did that in the study, and they made 3 classes, 1, 2, 3. This is a recurrence rate, 100%, that means they'll come back after 1 year of treatment. 0 means they don't come back after 1 year of treatment. T is 0 means that's the time you stop your pills during 1 year, and then you can classify them. After 2 years, the people in class 1, only 16% got their hyperthyroidism back. So these people, you would just treat for 1 year, and you tell them you have 80% chance that your thyroid will keep quiet for a while. Now these people, you tell them, we will have to treat you with pills for a long time. And if you don't want that, maybe we should do something else. Send you for scintigraphy and ablation or operation. Usually people choose for pills, but then you know you shouldn't stop. Here in the middle, you got to talk to your patient, see what he wants. Some advantages and disadvantages of the iodium ablation and the surgery. Yeah, the iodium ablation has the advantage that you don't have to be operated. It's relatively easy and it has the same effect. And about half to 25% of the people after the treatment, they stay euthyroid for a long time, so they don't need any pills anymore. And ultimately, obviously that's what we want, and patients also want very much. They don't want to take pills. Yeah, the disadvantage here, it's expensive. You have to send them to Colombia, where they stay 1 to 2 weeks. It's slow, so if you're in a rush because the patient has a lot of symptoms or atrial fibrillation, you shouldn't do this. Because it takes a few months for the effect to happen. You can imagine. You drink that, it goes in there, and slowly the thyroid starts slowing down. In Graves' disease, this is not true. In Graves', you have a high chance of hypothyroidism. So, you're treating Graves' with strumazole. You tell them, go to Colombia to do the treatment, then they come back and then have to take Euthyroid. That's a whole bunch of work for nothing, is what we think. Because that is, so this treatment is mostly for the toxic goiter or toxic adenoma, or for the non-functioning goiter. If they don't want to be operated, or you don't think it's a good idea, then you can do this. It doesn't always work, but you can do it again.
How about damage due to radiation? Is that something?
It's not a problem. It's something the patients worry about, but you can. I haven't seen numbers, but it's very uncommon. Pregnant people, you cannot do this.
Reason for the baby, the thyroid, it passes the
that's
placenta?
right, yeah.
Placenta, the baby also has a thyroid, no?
Yeah.
Yeah, of course.
And the breastfeeding, you can also know you have to stop breastfeeding during treatment. Surgery, of course, if you're scared for cancer, then you should do surgery because then you have a good specimen to determine if it's cancer or not. If there's obstructive symptoms, so someone cannot swallow, then this is the fastest way to help them. The advantage is here, you can do it here. It's faster, it's easier, and I don't know if it's cheaper. But the patients, they usually see it as a disadvantage to take off from work for 2 weeks to go to Colombia, they have to take a family member. It's a good treatment over there. We're very satisfied, it works well, but you're off island for 2 weeks. Another advantage is, nowadays people don't do full thyroidectomy anymore. Everyone does a subtotal thyroidectomy. So you leave a little bit of tissue, and that is enough in 50% of people to be nicely thyroid after the operation. These are the risks, of course. They're low, depending on the experience of the surgeon. But next to a thyroid, either parathyroids, we usually have 4, they organize calcium. And if you take them away, you have a huge calcium problem. You take many pills the rest of your life. Calcium and vitamin D. It's very unpractical. That's one risk, and you can touch your vocal cords. Our surgeons say this hardly happens.
Recurrent nodular, not vocal cord.
Yeah, you're right. I haven't seen numbers of them. I don't think they collect the numbers, our surgeons. But they say it doesn't happen. My last slide. There is basically 2 take-home messages I want you to remember. If you remember nothing of this, I hope you remember this. Only ask for an ultrasound of the thyroid when you have a good reason. Now, a good reason would be if you have a palpable nodule, then you should do it. It's a good reason. And if you're trying to figure out what the cause of your hyperthyroidism is. Hyperthyroidism means your TSH is low. And you cannot really see why it is. That's a good reason. But don't screen thyroids with ultrasound in asymptomatic people. There is evidence that does not result in earlier finding of thyroid cancer. Because that is ultimately the goal of screening, right? To find cancer in an early stage and to reduce mortality of that cancer. Asymptomatic screening doesn't help in that, so don't do it. The other thing is, hyperthyroidism, it's good to look for the cause, because Graves' disease, which is the most common cause, can in many times it can be treated for a shorter period of time. So you don't have to put the people on pills for a long time. It saves money for pills, it saves the patient's trouble, it saves you trouble controlling them, so it's good to look for the cause. Yeah, that's it.
Questions?
questions you haven't asked so far?
Yes, I had one question. In the clinical practice, like Dr. Cortez said, you have these patients with hyperthyroidism that are really like hyperactive. They are like some compare like we have a differential diagnosis, like people with maniac syndromes
Yes,
or
can.
cocaine or amphetamine.
Yes.
So when you take a patient that clinically is like in a high, and you give the treatment to avoid that and to decrease the metabolism, how is the addition to the treatment? Sometimes they really get tired of that because sometimes they were like in this state and now you put it down.
Okay.
You got problem with that?
No, I didn't. My goal is not to tell you everything about the treatment because actually when someone comes with a lot of symptoms, you should give them beta blockers also. You shouldn't give them only strumazole because strumazole is very slow. You should give them beta blockers. Usually we would give propranolol, you can give metoprolol too. We give them beta blockers. That controls the symptoms very fast. Until your strumazole does its action and your thyroid goes down, you give them that. Now, I have not seen anyone who complained that their hyperactivity symptoms were gone. The thing people do complain about is that they go back to their old weight.
Oh, yeah.
That is a big issue. So they gained their weight back and they were happy many times, and then they finally were on the correct weight. So you got to tell them because they stay hungry for a long time. So you start treating them and that hunger feeling doesn't go away right away. You got to tell them you're still going to be hungry, but you don't have a turbo motor anymore now. So stop eating if you want to stay this way. It doesn't work. My child always feels because they go back to their old weight. It's the same as treating HIV, which I do also a lot. People come with AIDS, they're very happy because they're thin. You give them pills and they're like, these pills make me fat. No, they don't make you fat. We're treating the disease which is killing you, but it's, yeah. That is something people complain about. You're back to normal, back to your BMI of 50.
Any question?
Hi, I have a goiter. I have actually the last time I checked it, my last testing, they said it was multiple nodules. I had multiple nodules, 5 nodules. One goiter was medium size, and the other one was small, and the other nodules were very tiny. They test my T3, T4. Every time they test it, it's normal. My weight is, well, I've never been a big girl. I tend, my weight just goes a little off, just a little, maybe just a pound or 2 off and on, not regularly. The last doctor I went to suggested surgery, but I don't want to do surgery. I didn't think they did enough testing, and I didn't think it was, to me it was a no-no. What was the biopsy? They did it. Yeah, biopsy failed. Symptom-wise, because they never really asked me any symptoms. When I went to the doctor, they never asked me like, okay, what symptoms you have, or they just saw the goiter and then they just may come to a conclusion, surgery. What should I do?
Now, generally, it's hard to go in your individual case. This is pretty complicated. I try to unentangle it because there's many diagnostic processes running at the same time. Now, I hope your doctor tried to disentangle it from his head, but it's pretty complicated because you've got to make more decisions at the same time. You've got to decide, are the symptoms caused by this disease? I don't think so in your case, so that's one thing. The second is, does the thyroid do its job well? So that's why you check blood. If those numbers are normal, then it's doing its job well. Then the third thing is, it's big. What's the problem with the bigness? For the doctor, it is usually, is it cancer or not? For the patient, many times, it doesn't look good, or it bothers me a lot, and also it could be cancer. These are different perspectives. I hope the doctor is always aware, but probably not always. You know, honestly, there's a short time, but these are different steps in your decision making, and you should address them each individually. Now, if someone has a multinodular goiter, which is Thyroid, we talked about that. You should make an ultrasound and see if any of the nodules should be biopsied. We should take a biopsy of any of the nodules. There is some issues. It depends how experienced the radiologist is, how experienced your pathologist is, how experienced the doctor is. Sometimes the doctor can decide that's going to be a whole hassle because he's going to get the test that one result back because he knows the pathologist which is there now. He's had bad experiences. So then he decides it doesn't look good on the ultrasound. I just had many patients where I did biopsies and I didn't get any results. Let me better be sure and do a diagnostic hysterectomy, because then for sure you're going to get good results. Now you can understand these are individualized decisions, where ideally you should be involved in the doctor's thinking process. But many times there's no time, or the doctor doesn't estimate you smart enough to understand his reasoning. I mean, that's how it goes. But you can always ask.
Because
Yeah.
he said follicular lesion. They said follicular lesion, which of course he doesn't know exactly what. If it's
No.
yeah.
So if you're in doubt about your treatment, the patients which make me think are the ones who know what they're talking about. So if you ask your doctor, what's the Bethesda class? Either he will be mad at you because you ask him something that he doesn't know. Well, then you should go to another doctor. Or he's like, that's a good question, I should know, but I don't know. And he will look it up and tell you. And he will come to a new decision. I mean, that's how you can test your doctor. Make sure you read the same guideline. I mean, it's there online. And you can ask him. And he will give you an answer, and then you're either happy or not, and you go to someone else. And that's how I would advise.
Because for me, I look at it like check my medical history, tell me if I have any other medical condition. They could affect my thyroid. Like for instance, I have thyroid, and I did had my myectomy to remove the thyroid 4 years ago. Before I had that surgery, I didn't have this. 1.5 years after but almost 1.5 years after my surgery, then I started feeling like.
Okay, these things you talk to your doctor and see if he gives you a satisfactory answer. And otherwise, ask for another doctor. I mean, we are a free country. That's fine. Maybe he's not happy or she's not happy, but it's your help. Any other questions? Now, don't send all your thyroid questions to me. If you look something up, then you realize that you should have done some things better. That's how it goes. But as GPs and internists, you got to know everything. So sometimes you look something up and you think back of some cases and you're like, I probably should have made different decisions. So right now I happen to know a lot about this thing. But yeah, it's good to study this and to realize some things. No more questions? Ben.
How fast should a GP send a Graves to
Depends
the
on the
internist?
symptom.
Depends, of course, yes.
Numbers say nothing. You can have people with hardly any symptoms with an FT4 above 100. And you can have someone with severe weight loss, atrial fibrillation, everything with an FT4 of 40.
Yeah.
Look at the patient and just give them beta blockers. That's all you should.
Yeah.
If you don't really know what to do, just give them propranolol 3 times 10 milligrams, and then that's always good.
Yeah.
But it depends on the symptoms. There's something like a thyroid storm also. Sometimes there's a rush.
There was recently, I think my last days in the hospital,
Yeah.
there was a
Yes.
thyroid storm with
Yes.
an atrial fibrillation, decompensation cordis.
Thyroid storm means that there's life-threatening symptoms. There's tables, you can just Google it, and there's calculators how probable in this individual patient the thyroid storm is. There would be fever, there would be altered consciousness. Those are some symptoms you should look for. But and again, don't get fooled by the FT4 number. You can have a thyroid storm at FT4 of 40. Yeah. But you don't have to be so in a rush to answer your question.
No, because I'm like thinking how much should I do myself before sending it to the.
You can diagnose
There's
Graves
these
clinically.
guidelines, yeah.
You can ask for TSH receptor antibodies because that's very handy because it takes 2 weeks. So
Okay,
if
yeah.
you ask for them and then I can see them and then I'm done in one. It saves us one consultancy.
Of course.
And there's how the GPs who do everything, and the only thing I have to do is continue the treatment. Yeah. I think there are some GPs who treat Graves themselves still. Anyone? I think so.
I think so.
There's no inhibition to do so if you feel experienced. Usually they're sent to the internist, but there are some GPs who do. Unfortunately, there's also GPs who have them for 10 years on strumazole, and then the first thing I do is stop the strumazole, and then that was it. That was my contribution.
That's good. Nice.
Okay. Thank you. I think our chairman has left
Yeah.
the room.
I don't know